really want to thank Dr. Vikas, Kapil, and Dr. Ruth Karron, who are joining us tonight to talk about the vaccine, its development, and its distribution as it relates to COVID-19. This is my fourth mayor's meetup since the pandemic began. It's the third virtual one. We did one in the park with our police department, but over the summer. And we are thrilled to have y'all join us today. We're going to talk about the vaccines, as I said, and if people at home have questions, you can use the discussion button on Zoom or in the comment section on Facebook. And I have people here, Jennifer and Kathy, who are going to monitor that for us, so I don't have to monitor it myself. Let me introduce our panelists and let them each tell you a little bit about themselves. Dr. Ruth Karron heads the Center for Immunization Research at the Johns Hopkins Bloomberg School of Public Health, and Dr. Vikas Kapil is the Chief Medical Officer and Medical Director for the Georgia Department of Public Health, and he began his position just a few months ago once we were well into the thick of the pandemic. I have been fortunate to hear Dr. Karron speak in a crisis management program I am participating with other mayors at the Bloomberg Harvard Institute. So with that, Dr. Karron, would you like to just briefly tell us a little bit about yourself?
Sure. Well, thank you so much, Mayor Deutsch, and it's really very nice to be here with you tonight. So, as you mentioned, I'm a pediatrician. I'm trained in infectious diseases, and I've worked on respiratory viruses and respiratory virus vaccines for much of my career, which comes in handy these days. And I've also served in various policy capacities, and I've been a member of VRPAC, which no one had ever heard of, right, before 2020, the FDA Advisory Committee, and also ACIP, which I think is a little closer to home for all of you, that advises the CDC on vaccine use. So great to be here with you tonight.
Thank you. And Dr. Kapil.
Thank you, Mayor. Really a pleasure to be here with all of you and with Dr. Karron. As you mentioned, have just joined the Georgia Department of Public Health a few months ago, and I'm on a long-term secondment from the Centers for Disease Control and Prevention. Prior to coming here to DPH, I have been at CDC about 19 years. And in various centers, most recently in the Center for Global Health at CDC. My training is in emergency medicine and in public health. And prior to CDC, I was at the University of Cincinnati Medical Center. And it's a pleasure to be here with all of you. And I look forward to chatting with you and the audience about our efforts on COVID vaccine or other questions as they arise. So thank you again.
Thank you very much. And again, thank you for joining us. I want to take a second and give a quick overview of what is happening with COVID in Georgia, but mostly in our home county of DeKalb, and a little bit about our city of Dunwoody. So everyone knows, I would hope that we're in the middle of a surge at COVID. I'm not sure what number surge this is, because I'm not sure. I think they've been more like waves that go way up. So I just am sharing a quick little bit of data. And there's a new chart for my regular readers. DeKalb County started this week with a chart that shows, rather than cumulative cases by zip code, we're now doing percent growth 2 week over 2 week. And Dunwoody's up in the little top of that's pink, which means we've had more than a 5% growth in cases in the last 2 weeks, which isn't totally surprising if you've been reading what I write. Plus, that is the trend everywhere else. Dunwoody had last week the largest growth in cases, in new cases that we've ever had. And I know that lots of people say, well, don't talk about cases, because lots of people get it and they do okay, but let's talk about hospitalization. So Jennifer, can you flip to the next slide, please? So this is the current situation. It's actually a few days old, I believe. It's from a couple days ago, of hospitalizations related to COVID in Georgia. And you can see that we are close to, if we've not already exceeded, the height of hospitalizations this summer. And generally speaking, hospitalizations follow by a few weeks the numbers of new cases. And then often hospitalizations follow, deaths follow an increase in hospitalizations. We'll have to wait and see if that happens. But deaths in Georgia, they're increasing as well, but perhaps not as rapidly. There's been some new treatments that have been developed, as COVID has progressed, or the time has progressed, physicians and hospitals have learned more about treating it. There's been new treatments available. And so I believe that's helping. But we do have, this week we had a record level of new COVID patients hospitalized. And so everyone needs to continue the practices that I talk about all the time: mask wearing and social distancing. And so a few weeks ago, there is no time in COVID time, but in November, I believe, Dr. Karron gave a presentation to the mayor's group that Harvard Bloomberg is sponsoring on crisis management. And it was so interesting to me, and explained the process of vaccine development to me, a person who has no scientific background. And so I thought it would be really helpful to share your knowledge, Dr. Karron, with the residents of Dunwoody and beyond, so that people can start to understand and make wise choices as it relates to the vaccine. And so with that, I turn it over to you.
Great. Okay, so thank you. And I think I have probably some slides that will come up. And so Mayor Deutsch, when you said, you said something about COVID time, and I was just reflecting on how much has happened in the few short weeks since I gave that mayor's conference. An awful lot has happened. When I came to talk to the mayors, we were talking about vaccines that are being tested in the US, and this slide is still relevant and pertinent, but some things have happened, as I think all of you know, and as we'll talk about, with those mRNA vaccines. So I think if you could click to the next, yes, thank you. This actually just shows the 3 types of vaccines that are being evaluated in the US right now, or have been evaluated. The first type that we've all been hearing a lot about are the mRNA vaccines, one developed by Pfizer and one developed by Moderna. Adenovirus vectored vaccines, those trials probably will be completed in the next 1 to 2 months, maybe closer to 1 month, AstraZeneca and Janssen. And then finally, there are what we call recombinant protein vaccines, and those studies are actually just getting started. So next slide, please. Just something about how these trials are done. And for somebody like me who's worked on vaccines for decades, it's really been remarkable to see how this has played out this year. These trials enroll 30,000 to 45,000 people. The Pfizer-BioNTech trial had about 45,000, and the Moderna trial had a little over 30,000 people. Vaccine trials, what we call efficacy trials, the trials that are done before a vaccine is licensed, vary in size. But in general, this is about 5 to 10 times more people in a study than we usually have in vaccine trials. And the way these work in general, it certainly was true for the Pfizer and the Moderna trials, is that half of the people in the trial get vaccine and half get placebo. And the placebo is just it's a saltwater injection. And the trial is double blind, which means that the participants don't know what they got, the people who are observing them don't know what they got, and that's so that the outcomes. So what happens to people can be assessed without bias. And one of the other really important things is that every single trial participant is followed both to determine safety and whether the vaccine works. So when we think about, the rapidity, everybody hears Operation Warp Speed and they think about the fact that, oh my goodness, it's been less than a year and already we have vaccines and they're rolling out, and is this safe? Is it appropriate? One thing just, in the first instance to have in mind is just how much safety data there is over a period of at least roughly 2 months after vaccination in a very, very large number of people. So how do we figure out if a vaccine is safe and effective? The participants, who, as I said, are blinded, as the study investigators are, report their symptoms and their illnesses to study investigators. And then an independent committee reviews this information. Sometimes, and you saw this with the AstraZeneca trial, if there's a serious illness, there's a study pause, which is completely appropriate. It's what should happen. And, especially in these large trials, illnesses occur in people sometimes, and we need to stop and figure out what's going on. So then what happens when the trial is, when enough cases of disease have happened, the information is brought to the FDA, and the FDA can issue an emergency use authorization. This is not a full licensure, but it's based on very specific information that the FDA has asked for emergency use authorization applications. This was done on December 11th for the Pfizer-BioNTech vaccine, and there's a hearing on Thursday on the 17th. For the Mrna vaccine, and probably there will be, my guess is there will be an EUA issued for the Mrna vaccine on the 18th. So we'll have not one vaccine, but 2 vaccines. One thing that I wanted to mention about these hearings is, and I realize I meant to have it in white, it's in blue, but these hearings are open to the public. So if you want to tune in and listen to how the data is presented by the FDA and by a company to an independent panel of experts, and what the questions are that are raised, you can tune in on Thursday. It'll be most of the day on Thursday. And then once vaccines are available to the public, the safety assessment doesn't stop. It doesn't stop because trial participants are still followed in the trial, and it doesn't stop also because there are ways that both FDA and CDC will collect safety data even after an EUA is issued in people who receive vaccine as part of the vaccine rollout. Next slide. So what do we learn from these trials? We learn about the rates of COVID-19 illness, and we compare them in people who receive vaccine and people who receive the saltwater placebo. What the trials tell us is whether a vaccine can prevent COVID-19 illness. Importantly, what they don't tell us, and I think many of you know this just from reading the newspaper, is they don't tell us about transmissibility. That is, they don't tell us, they will tell us whether a vaccine will keep you from getting sick, either mildly ill or seriously ill, but they won't tell you if the vaccine will keep you from giving it to your friend or your family member or your neighbor. Next, please. So just a word about, an EUA, which before 2020, probably very few people had actually heard of. So emergency use authorization is used in public health emergencies when researchers might not have all the information that the FDA would typically need before approving a drug. And manufacturers have to provide data to show that the benefits of the product outweigh the risks. There are very specific, the FDA has issued very specific requirements for an EUA for COVID-19 vaccines. And I will just mention that each of these vaccines, the Pfizer-BioNTech vaccine and the Mrna vaccine, are 94 to 95% effective against any COVID disease and 100% effective against severe disease. And this efficacy was shown across age groups, so in the elderly as well as in the young, and across diverse racial and ethnic groups. And I think there was, there was a very concerted effort and very important effort to be inclusive and to have diverse populations in these studies. So then after the EUA, what happens? People make decisions about vaccine distribution and deployment. The national academies issued a framework for thinking about this. The CDC issues the recommendations with input from the ACIP Advisory Committee on Immunization Practices. In some cases, professional organizations weigh in, and as we're about to hear, I'm sure, from Dr. Kapil, it's really states that make the final decisions, taking all of these expert recommendations into account. So where are we? There is a light at the end of the tunnel, I think very, very clearly, but just to say, this is not a time for us to let down our guard. This is not a time, even for those people who get vaccinated, this is not a time to throw away your masks. This is not a time to congregate. Until most of our population is vaccinated, we will not have the kind of herd immunity that will allow us to stop these non-medical measures. So both are really important. And with that, I'll stop.
That's great. I have a few questions for you, and then we'll have Dr. Kapil do his presentation, and we'll come back to some of the questions. Quickly, is there a difference between the Pfizer and Mrna vaccine?
So the most important, so they, in terms of both how they're made and how and their efficacy, how well they work, they're virtually identical, and their side effect profiles are virtually identical. An important practical consideration is how they're stored. So the Pfizer vaccine has to be stored at ultra low temperatures, and the Mrna vaccine is a little less temperature sensitive, but they're very, very similar vaccines.
And we have a question from Marjorie, and it's a fairly specific question, but it's, she has an autoimmune disease and has been told she can't get the vaccine. She wonders about the difference between a vaccine with live virus and versus a dead virus vaccine. And if you could expand maybe into pre-existing conditions and the ability to get the vaccine in general, that might be helpful too.
Yeah, and so I think there's going to need to be, what I would say is that people will need to speak to their physicians to get specific advice. These are not live vaccines. mRNA vaccines are not live vaccines. There's a piece of RNA, of nucleic acid, that goes inside your cell, and then your own body makes the protein, and then you develop immunity to that protein. I think for people with autoimmune diseases, that's probably a question to ask your physician. With these trials, in terms of comorbid conditions, as we call them, things like high blood pressure, heart disease, that sort of thing, those individuals were specifically enrolled in the trials, and the efficacy was similar in those populations.
Are there any side effects that you find worrisome in the trials? Is there stuff that's been reported that you
So I will say that these vaccines, and this is not worrisome, but it's just important for people to understand. So when they get the vaccine, this sort of side effects that we see are similar to what people have reported with the shingles vaccine, with Shingrix. And that's a vaccine where, people don't feel very well often for about 24 hours after they get the vaccine. And it's particularly after that, the second dose, all these two vaccines are 2-dose vaccines, and it's particularly after that second dose. And that's just something people need to prepare for and be aware of. I think that those are really the big issues. I will just say that in the UK, there were a couple of people who had an allergic reaction when they were first rolling out the vaccine. I will say that everyone who gives vaccine is prepared and should be prepared for people to have an allergic reaction. Those can happen infrequently. And the current recommendation now is people who have a history, who carry an EpiPen, should consult with their allergists, but many of those individuals are getting vaccine.
And then so you touched a little bit on it, but most vaccines take forever to be developed, and this took 10 months. And
Right.
I think part of what I read is that the companies were already working on some of the technology, perhaps, but why should the average person be confident that 10 months was sufficient?
Right. Well, I think so. You touched on something really important, which is, yes, these two companies didn't, particularly BioNTech, which is the folks who made the mRNA vaccine that Pfizer acquired, and Moderna didn't start working on mRNA in January of 2020. This was a technology that they'd been working on for many, many years. The other thing is that, frankly, because of the resources that our government appropriately, you and I, taxpayers, put toward the development of these vaccines, we were able to not compress the safety evaluations, but do things at financial risk that under normal circumstances we wouldn't have done. Companies started manufacturing vaccines in April and May for rollout. We wouldn't do that. A company wouldn't do that at financial risk before they even knew if the vaccine worked. And also because of that, the companies were able to go very quickly from phase 1 to phase 2 to phase 3, again, because of that financial investment. The other thing is the size of the trials that I mentioned. What happens is when you do a trial that is that big, if you're trying to look at cases of COVID in vaccinated versus placebo recipients, the more people you enroll, the faster you can get to that result. I mean, we could have had trials that enrolled 5,000 people, but then we might have been 2 or 3 or 4 years in figuring this out, and we didn't have that time. So it's really this, again, and that comes down to investment leading to a bigger trial, which also means, as I mentioned, that we have so much more safety information about these vaccines than we might otherwise have.
That's really helpful. So Dr. Kapil, could you talk to us about how this is going to work on the ground, per se, in Georgia, in terms of distribution and everything practical we need to know?
Great. Thank you so much again, Mayor. And thank you to Dr. Karron for such a concise and clear presentation on the vaccines. I don't normally have the luxury of having someone do that so well in advance of this discussion. So Dr. Karron has very clearly laid out for you what an exciting development this is for public health and what the future holds for us, the light at the end of the tunnel. And hopefully that light will get a little bit brighter at the end of this week, because as she mentioned, we have a second vaccine which will be under consideration for an emergency use authorization later this week. And that data for that vaccine has also just been posted on the FDA website. And as she pointed out, all of that data, both for the Moderna vaccine, which is going to be considered this week, and the Pfizer vaccine, which was considered last week, all of that data, that entire package is readily available for people to take a look at. And I've actually been quite impressed. I just looked at the materials earlier today. It was just posted this morning for the upcoming meeting. And I've actually been pretty impressed with how well it's put together, and it's really not in such deep technical language that I don't really, I think you can get the gist of it, even if you're not a specialist in immunology or in vaccinology or in the medical field. I think people would really enjoy looking at that and appreciate the data that's there and presented in a very transparent way. So the vaccine is indeed great news. We're very excited about it here in Georgia, as of course all states and jurisdictions around the country are, because it has the potential to bring us to some sense of normality in the next few months or by spring and summer. As Dr. Karron already touched on, it is very, very, very important to understand that it is just one important tool in dealing with this public health crisis and this pandemic. We have to remain very diligent to use all of those tools, including the basic public health prevention measures, wearing a mask, keeping distance between yourself and others, hand washing. If you haven't already done it, please, please, please go out and get your flu shot. It's not too late. We're just into mid-December. And avoiding gatherings with individuals who are not in your household. And of course, being very, very cautious about trying to avoid unnecessary travel and traveling during the holidays. And of course, we've seen some of the outcomes of that related to the surge and the data that you showed recently from previous holidays in the last few weeks. So next slide, please. The administration in Georgia, like Dr. Karron alluded to, and also like across all 64 jurisdictions in the United States that have been receiving vaccine very recently, just within the past few days, is a very complex undertaking, as you can imagine. States do receive the vaccine from the federal government, and you've heard a little bit about Operation Warp Speed earlier. And we are working very closely with the Centers for Disease Control and Prevention, the Department of Health and Human Services, to help us work with all of the guidance that they've developed, the Advisory Committee on Immunization Practices, the ACIP, which helps us think about how best to use a new vaccine like this. So Georgia's phase 1, which is the very first phase, the initial allocation that we received from the Pfizer allocation was roughly just under 85,000 doses. The phase 1 allocation, we've received only the very first shipment of that. The rest of it is supposed to be coming in tomorrow and Thursday to the state of Georgia. So that 85,000 doses will be here by Thursday or Friday of this week. It's already been allocated and will be heading out to public health clinics, to district health departments, and to a number of hospitals and clinical sites around the state. Additional shipments will come, including for Metro Atlanta, within the next couple of days, and really to the entire state. If you look at the map, it's really widely distributed around the state. It's been a relatively, over the last couple of days, sort of a ramping up process. The initial allocations were a relatively small number to sort of test the system, to evaluate our ultra cold storage capacity, and it looks like so far all of those systems have been working well. So we expect this to ramp up through this week. Now, with that impending emergency use authorization discussion that's supposed to happen with FDA on the 17th, we anticipate, again, as Dr. Karron said, we hope that an EUA will be in place very shortly after that. Immediately after that, the CDC ACIP will meet again to consider the second vaccine, the Mrna vaccine, and will provide additional recommendations there may be some very minor or subtle differences between the vaccines, and that'll all be sort of fleshed out in those guidance documents. Once that EUA is authorized and the ACIP meets, very shortly or almost immediately after those events, the next allocation or the next shipment will begin to ship to Georgia. We do anticipate immediately after the EUA, the shipment of Mrna vaccine to begin, and we're anticipating an additional 174,000 doses of Mrna vaccine over the next week or so. And this is not a one-time process. So this process then, once this sort of rhythm or cadence is established, we will be looking at ongoing ordering. We've enrolled already over 600 providers for vaccination services here in Georgia. That may be on the next slide, but we would anticipate that ordering would continue, and those orders and that allocation would continue to come in over time as this whole process rolls out over the next few weeks and months. This is our current vaccination scheme. We look at this kind of approach based on the ACIP guidance. As Dr. Karron mentioned, we're not totally bound by it, and states do have some flexibility. And I'll give you a couple of examples of that, one specifically that I think is important. But the point here is that this is an interim kind of guidance, and we may make some minor adjustments here and there as we go. A lot of that predicated on the supply that we have available to us, the allocations that come week by week by week, and also what kind of demand we have in each of these categories. So right now we are, if you look at the very left of this chart, we're in phase 1, and right now we're in phase 1A. And phase 1A, which is at the very top, the first two bullets on the left, is the current guidance and the current recommendation for the phase that we're in right now, which is healthcare workers, people with direct or indirect exposure in clinical care settings, and the potential to be exposed to COVID. And then second group would be the long-term care facility staff and residents. Those are a very, very high-risk group, and they have certainly been very disproportionately impacted since the beginning of this pandemic, both in the United States and in other countries as well. After we make a significant dent in that phase 1A population, and by the way, we have a significant number of folks in those groups here in the state of Georgia, probably somewhere in the neighborhood of well over 500,000 people, 550,000, perhaps approaching 600,000, depending on exactly how you define each of those groups. Following those groups, we will move to the next phase, which would be phase 1B, and that will include a lot of our essential workers, and that is the recommendation from ACIP as well. That's consistent with that recommendation, which means, and there are a whole lot of people in that critical workforce occupations, air traffic control, nuclear power plants, power lines, food processing, transportation, and so on. We are going to also, police and fire. We are also going to add to that group for Georgia in phase 1B, older adults over the age of 65 with comorbidities and their caregivers. That again is a very, very high risk group and again have been very significantly and disproportionately impacted with COVID, with a very significant percentage of the mortality being in those age groups, both in residential care settings, in extended care facilities, and also in home settings. Then we will move through further phases after that. Phase 1C, shortly to follow phase 1B, hopefully, would be other adults 65 and over, and adults below the age of 65 with comorbidities, because we know that there are a lot of conditions such as diabetes, immunosuppressive states, people with cancer, kidney disease, and so on, who are at increased risk for complications and the sequelae of COVID. Subsequently, and again, depending on supply and the allocations that are available a couple of months down the road, by early spring, we would then move into a number of other phases, phase 2, phase 3. You can see there are a whole bunch of other groups that will need to be prioritized, including people who live in congregate settings, people who are incarcerated, people in other congregate setting, dormitories, things like that. And young adults would come later. And then eventually, hopefully, we will also be thinking about children. Now, neither of these vaccines is authorized at the moment for children. The Pfizer product does have a recommendation for use in 16 and older, and the Moderna product, which is just going in for an EUA consideration later this week, is for 18 and older. So children are a group that right now, and hopefully, that'll be something that'll be addressed in the ongoing work that's going to be continuing with these vaccines and the other vaccines that are in the pipeline. So next slide, please. I do want to touch on one additional thing. If you could just go back for one moment, Jennifer. I do want to touch on one additional thing, and this is perhaps, we've talked about how do we exactly lay out the priority groups and how do we do our prioritization and the cold chain requirements, the ultra cold storage for the Pfizer vaccine and so on, and all the logistics and getting this to all the remote corners of the state and the small towns and big cities. I think one of the major challenges that we will also have to deal with is the issue of helping people understand in a very open, transparent way about the vaccine. And the kind of presentation that Dr. Karron gave, I think goes a long way towards helping people understand what the basis is for the data that we have used, what the results are of these trials, what does an emergency use authorization mean, and the fact that people can readily and very easily go to those data sources themselves and look at and evaluate the data themselves. The other thing that's really important to remember is that the committees that are looking at this data on behalf of the Food and Drug Administration and the Centers for Disease Control and Prevention are independent committees. They are not government employees. They're not working for the government or for the pharmaceutical companies. They are independent committees of experts, in most cases, leading experts in their fields who are looking at this data on behalf of us here in the United States. So there are people who are concerned about the kinds of issues that you raised earlier, Mayor. And I think that it's incumbent on us to have these kinds of discussions, make this kind of information available, particularly for those communities where where there may be less confidence than we would like in the safety and the efficacy of these vaccines. We would really like those folks, especially those that are disproportionately impacted, because this is a tremendous opportunity for us to address this major public health crisis. We want as many people as possible to feel comfortable taking the vaccine. So I'll stop there, and I'll be happy to see if you have any questions. Or
I do, and you summed up beautifully why I wanted to do this presentation tonight, because I want, and of course it'll live forever on the internet and we will share it. And I hope everyone shares it, because I want to get the word out about how we got here today. And so I have a couple of questions. One is when you were talking about the 1A and the 1B and I guess 1C and 2 and all that, how does that work logistically? So if you know that you have 500,000 people, give or take, in phase 1A, how do you know, how are y'all going to know when it's time to go to phase 1B?
Yeah, so we have probably a team of about 30 people here at the Department of Public Health who are thinking exactly about these kinds of things and the logistics and the progression from one phase to another. There are a lot of things that'll go into decisions like that. You know, we're so early in this process right now. Decisions about what kind of supply we have available, and assuming that both vaccines receive their emergency use authorizations, what that translates into in terms of week after week, what kinds of allocations we're able to obtain, what kind of demand we have. And that's sort of why one of the reasons I was getting to that demand issue. And it's so important to help people understand and to build confidence in these vaccines. So based on those kinds of things, we'll decide. And I don't think that every state will be at exactly the same stage all the time. And in fact, you know, some states will do an initial phase quicker and they may move a little faster, but then they may be at that phase a little longer. So, you know, there will have to be some flexibility, and it may be to some extent dictated by what happens with supply and what happens with people's confidence in the vaccine and the other vaccines that are also in the pipeline. So, you know, hopefully in 2 or 3 months, we'll have a couple of other vaccines also on the scene.
Yes. So I'm going to ask a couple specific questions, and then for you, Dr. Kapil, and then when we get finished with those, I'll throw the rest of them out, and Jennifer can also ask questions she's received online. But so Gary emailed us and he said, how will a person who's over 65 be able to prove their comorbidities so that they can qualify for the 1B distribution?
Yeah, you know, it's a good question. I think that the easiest thing to do is, you know, people can always be asked for about their age. I mean, that's something that's pretty easy to do, like, you know, looking at identification or looking at a driver's license or anything. To be very frank, I don't anticipate that we will be doing a tremendous amount of sort of vetting and policing, if you will. I think that, you know, logistically, it would be very difficult when we're trying to vaccinate thousands, tens of thousands, hundreds of thousands of people. So most likely it'll be, you know, I think it'll most likely be on the honor system. And I think most people have been really very, very, very cooperative and very worked with us in a very positive way, understanding that any, you know, any dose that doesn't go to the right kind of, you know, is not used in the right phase is potentially putting someone at risk. So we're trying, but I don't anticipate a tremendous amount of policing or vetting.
That's helpful. And Daniel asked if they would be free and exactly, you know, once they're widely available, do you anticipate them being distributed through the drugstores, for example?
Yeah, that's a great question. So the answer to that question is that for the individual receiving the vaccine, in almost all cases, it would be free of charge.
Okay.
There are some mechanisms in place where providers may be able to get reimbursed, for example, from insurance companies or from Medicare, from Medicaid, for administration charges, which is pretty common, but just for the administration. The vaccine itself is not a chargeable kind of an item. People who don't have insurance are also able to get the vaccine. There is a program administered by HRSA, which makes administration costs, which can reimburse administration costs to providers who take care of uninsured patients. So Hopefully that
helpful.
answers the question.
I think that was great. And the distribution question, like I went to, where did I get my flu shot? At Target. So what do we anticipate? I know these have
Sure.
complications, the 2 doses and the storage, all that.
Sure. Yeah, so the initial enrollment right now is for providers that are really focused on that phase 1A population. Right. But I do anticipate, and this also touches on that earlier question about vetting, people with comorbidities and all that. I do anticipate that we will be moving as quickly as we possibly can between phase 1A, 1B, 1C, onto phase 2. We anticipate moving through those phases pretty quickly. So as that happens, the demand will likely increase because those populations are bigger. We do anticipate many other providers being enrolled in this provider enrollment process. So yes, I do anticipate in the next few months, we would be seeing many, many more pharmacy providers, for example. Many more doctors' offices, hospitals. There is a process for them to enroll with us using our existing immunization information systems and so on. And then there are some reporting requirements for those providers as well in the state's immunization system so that CDC and the Department of Public Health can gather that kind of critical information, which will be important for evaluating these vaccines later.
That's really helpful. So either of you can answer this question. So there were a few people who asked about how long the vaccine is going to last once you take it, presuming you get both doses. And is it going to eventually be like the flu shot where you'll need to get it annually? So whichever one of you feels comfortable answering that.
So the honest answer is we don't know yet. Part of it, when we've done these trials, the people who were enrolled earliest were enrolled in July and from there on out, and it's December now. So we only have at most about 5 months or so of follow-up. One of the things that's going to happen, there are people still enrolled in these trials, and part of what we're doing is seeing what the duration of protection is. How long will the immunity from these vaccines last? So far, we immunize against flu every year for a couple of reasons. One is that it's true that the immune response to the vaccine wanes a little bit, wanes significantly every year. But the other reason for flu is because actually the viruses change. And so far with this virus, with the SARS-CoV-2 virus, we don't have evidence of that kind of change, the kind of change that we see with flu. So I think that the short answer is time will tell. The other thing just to say is really our goal with vaccination is to prevent severe disease. That's really what it's about. So if we find that people can get, I think people will get reinfected with this virus, but I think when they get reinfected, the hope is, they'll have a cold, or they might have a sore throat, or they might have a little bit of a cough, but they won't have severe disease. And so that would really be our indication for revaccinating over time if we need to do that to prevent severe disease.
That's really helpful information. And I think that you touched on the fact that it is showing to be very effective in preventing severe disease.
Well, so I just have to say it's very effective all across the board.
Right.
94 to 95% against any disease. And just to sort of put that in perspective, so we didn't know anything about this virus before January. And even by April, we were learning about the epidemiology as we went. And when people were setting targets for how effective this vaccine, what was a minimum efficacy, people were talking about 50%, right? 94 and 95%, it doesn't get better than that for a vaccine. It's really quite remarkable.
That's very exciting. Can we go back to the children issue and the vaccine potentially being available for them? And do you have a timeline or an instinct that that's going to happen?
Do I?
Karron, you want to?
So I think, I think one of the things we need to do, there are studies being planned in children. These studies will not be the same kinds of studies. So they're not going to be 30,000 person efficacy studies. There'll be smaller studies, importantly, to see, one, whether these vaccines are safe in children, to make sure they're safe, and also maybe to look a little bit at the dose, because it turns out, children are much better at making immune responses than adults. And it also, they are, they're much quicker to respond in all kinds of ways. And one of the things we want to make sure of is that we know that this vaccine causes some fever and some achiness and that sort of thing. We want to make sure that the reactions aren't too severe in kids, and we may have to adjust the doses. So there's that piece of it. And then we want to actually look at the antibody responses. So we'll be doing studies in smaller numbers of children and have those data before we think about immunizing kids. And probably, my guess is that's really probably something for the second half of the year, the middle of the year, or the second half of the year.
Okay, that's really helpful. So I'm going to turn it over to Jennifer to see if there's questions in the comments.
And we do have questions there. I believe this one probably is for you, Dr. Karron. This is from Jose on Facebook, who writes, given how easily COVID can be transmitted, what percentage of the population has to take the vaccine for the spread to be controlled?
Yeah, so we don't precisely know the answer to that. There are people who are using mathematical models to think about that. People are talking about something like 80% of the population being vaccinated to provide enough herd immunity. But again, we don't know that these vaccines prevent transmission. It would just be that if 80% of the population had their own immunity to protect themselves, then that might be sufficient. But something like that, 70 to 80%.
We also have a couple of questions, one from Hazel and another one in the chat, asking about if the vaccine would be effective for someone who has already contracted COVID. Is there any benefit to the vaccine?
Yeah, so a couple of things. The answer is there aren't a lot of data about that. Both companies, even though they screened people, they didn't intentionally enroll people who they knew had COVID before they were enrolled, but they measured everybody's antibodies at the time of enrollment. And in fact, as not completely surprisingly, some people had been exposed to and infected with COVID and didn't know it. So they had antibody. It was such a small number that they can't really look at the effectiveness of the vaccine. But what we're saying right now is the immunity that's induced by these vaccines is in some cases many, many fold higher than the antibody responses to the natural infection. So we're encouraging people even people with a history of COVID to get the vaccine.
And Dr. Kapil?
Yeah, no, I was just going to say, I might add to that in the administration on a large scale throughout the state, we do not have any plans to do any kind of testing or anything like that before administering the vaccine. So even people who have a history of COVID illness, there's no contraindication for them to also take the vaccine. Of course, as long as they're not acutely ill.
And Dr. Kapil, this is a very specific question that perhaps you can answer. This gentleman is on medication for hypertension, is being monitored for prostate cancer. Would he qualify for the 1B group in Georgia?
Did he by chance mention his age?
No.
Okay.
I'm going to double check in the chat, but I don't believe he mentioned his age.
So we contemplate, what we're contemplating is that in the 1B group would be most likely would be people 65 plus with comorbidities. So if he was 65 plus, which he may be, then yes, he would be eligible for phase 1B. And if not, if he's younger, then he would also be eligible in immediately the next following group, which would be phase 1C. And like I said earlier, I do anticipate, depending on how the supply flows and the allocations come in, we do anticipate trying to move through those phases as quickly as possible. It's not, we don't have to finish everybody in one phase before we move to the next phase. We just want to try to get through as many people as we can. I hope that answers the question.
Yes, thank you.
Jennifer, can I jump in really fast?
Of course, I'm going to close out for a sec.
So for the regular person, like the gentleman who typed the question in, are our primary care physicians going to know enough to advise us about vaccines? How are people going to find out the information, especially people with pre-existing conditions or comorbidities, for example?
Yeah, that's a great question, Mayor. We are working on a lot of fronts to get that kind of information out. We are working with many different healthcare providers, including physicians, nursing groups, hospital personnel, trying to get information out about COVID and about COVID vaccine. We're also trying to disseminate information, both from organizations like the Centers for Disease Control and Prevention, and also our own communication materials. I do think that many physicians have so many people asking that many physicians have actually, I like to say that there are a lot of doctors out there now who have become part-time epidemiologists and part-time infectious disease experts. So yes, I do think that many physicians, advanced practice nurses, many different kinds of providers in the community will be able to address these questions in general, and also for special circumstances where these types of questions may come up.
That's great. And just, these are sort of basics, but I think it's important. So when people get the Pfizer in the first shot, they have to get the Pfizer the second shot, correct? You don't get one Pfizer and one Moderna, right?
Yes, that's also an excellent question. And at this point, the recommendation is that if you receive the Pfizer vaccine as the first dose, then the second dose would also be the Pfizer vaccine 21 days later. And if it's the Moderna vaccine, then 28 days later, you would get the Moderna second dose. That's exactly right. And
there's going to be, I think I read that patients are going to get a card. People are going to get a card that tells them what they got and take a picture of so everyone, if you get vaccinated and you have a smartphone, you should take a picture of the card first thing, so that if you might misplace it, like I might misplace it, you have it on your phone. And so you'll be able to refer your provider back to what you got. You'll be able to show them your information. And Jennifer, are there other questions? I know we're up against the time, but I'm hoping that we can get maybe people's questions answered, just because it's so important.
We do. Allegra touched on this on Facebook, wanted to know the difference again between the two, Pfizer and Mrna. And Dr. Karron, if you can touch on that briefly.
Sure. So they're really remarkably similar, right? So the way these vaccines are made is there's mRNA inside, and then there's this coat that's called the LNP coat, the lipid nanoparticle. The coat is probably a little different between the two, and that's part of what accounts for the cold storage differences. But if you will, the guts of it, the guts of the vaccine are remarkably the same. And I think that's why the efficacy data and the safety profiles are really so very similar.
Hazel actually asked this question. Her indication is that the other vaccines are supposedly not as effective as those two, Pfizer and Mrna. Can you touch on that?
So I think time will tell. We have a little bit of data. We don't know for the Janssen vaccine, which I think is the one coming up next. We have no data on that one. There is a vaccine that was co-developed by AstraZeneca and the University of Oxford in the UK. And there were some preliminary data published on the efficacy of that vaccine, which was somewhat lower, probably on the order of about 65%, but there are some things related to dose and age that are not entirely clear for that vaccine. So I think it will be important to see the data from the US studies, which probably will be out in the next month or two, and we'll know a little bit more then.
And Dr. Kapil, just one more question. This is from Charlie in the chat, and you've touched on this, but I think it's an important point. He's asking about the cost of these vaccines. Do you need to show insurance? Do you have any idea the cost to the patient? And you mentioned a few minutes ago that these would be free.
That's correct. There's not supposed to be any cost to patients. And in addition, for people that are on various plans, in most cases, any copays or charges related to being out of network would also be waived. And for people without insurance, there is a program that HRSA is running, a federal program, which would provide reimbursement to providers who take care of patients without insurance to reimburse them for those charges related to the administration. So the only administration charges and no billing to patients directly.
Great, thank you. Thanks, Mayor.
First, and so I was muted. I think after 1,000 years of doing this, I would not make that mistake anymore. Dr. Kapil, would you like to just give us some closing thoughts?
Well, again, thank you so much for having me. It's a pleasure to meet you, Mayor, and to meet everybody virtually who's been on the line and asking these amazing and great questions. And it's also been a pleasure to meet Dr. Karron. It turns out we have a number of mutual good friends, but I've not met before. So I really do think this is a tremendous opportunity for all of us to put this pandemic behind us. Hopefully in the next 6 months or a year, things will be looking very, very different in Georgia and in this country with the advent of these vaccines, not only these two that we're already are with us, but others that are in the pipeline. So I'm very hopeful, and I love to think about how things will be different. I'm feeling very positive about this. It won't be easy. There's a lot of work to be done, and please get the word out. Folks in the audience, please help us get the word out about these vaccines and for yourself and for your family. Thank you.
And Dr. Karron, do you have any closing thoughts? Yeah, first, again, just thank you so much for having me. These were wonderful questions. It was wonderful to meet Dr. Kapil. Thinking as somebody who's worked on vaccines my whole career, this is an amazing, set of events that have happened, that in a year we've had not one, but two highly effective vaccines that we can use. But the best vaccines in the world, the most effective vaccines in the world, don't do anything if they're not used. So it's really up to Dr. Kapil and his colleagues and all of you, all of the residents of the state and of this country and ultimately the world to really take up these vaccines. And I think for all of us to think about, this is the path forward. This is how we get back to doing the things in life that are really important to us. And so the time is now to begin.
Well, thank you. And I'm so grateful that you chose to share your time and your expertise with myself and the residents of Dunwoody and beyond. And we will share this information. Dr. Kapil, if there's anything that the city of Dunwoody can do to help, I know that a nearby city said they were ready to help distribute or whatever. Please let us know.
Thank you.
We have great providers, and we were a testing site for quite a while. We had a testing site.
We've had amazing cooperation and collaboration with jurisdictions across the state. So thank you so much, Mayor.
Yes. And with that, I will end this very informative session. And again, thank you so much for your time. And one day we will meet in person. So
Look forward to it.
thank you. Thank you.
Thank you.
Thanks, everybody.
Thank you so much.
Thanks.
Bye.
Bye-bye.
Bye.